What's up, y'all? It's Dr. Hall, and we're doing another video on proteinuria. What you need to know about proteinuria. Uh, I'm a nephrologist. I've been practicing for about 20 years, and we're basically trying to help you make the transformation from medical knowledge to clinical knowledge. We know you guys are smart. We know you guys know what you're doing, but sometimes bridging that gap from the medical testing and knowledge setting to the clinical setting is somewhat challenging. So that's what I want to do today. We're going to talk about proteinuria. Proteinuria is basically protein in the urine. Usually, most times it's Tam-Horsfall protein, which is lost in the distal tubule. But anytime you have persistent proteinuria, that's your indicator that something's going on with the kidneys. Usually, proteinuria is the first sign of kidney damage. That's why we always make a big deal about proteinuria. You can have transit proteinuria, things like urinary tract infections, orthostatic hypoproteinuria from being upright all day, fever, heavy exercise, and stuff like that. Sometimes pregnancy can cause it too, but persistent proteinuria is usually seen if there's primary renal disease, such as glomerular or tubular injury, or if there's a secondary cause, such as diabetes, hypertension, and so on. You can have some benign causes of proteinuria, which I mentioned earlier, some of the transient. Those are really not. When you check a urinalysis and you see protein in the urine, or you check a urine protein creatinine ratio, and then you recheck it in a week or two, it goes away. Usually, fever, acute illness, some type of stress causes those benign types of proteinuria. But typically what we see is three different types of pathways that causes proteinuria. Actually, it's four: glomerular, tubular interstitial, secretory, and overflow. And the main one I want to look at is glomerular. That's what we deal with when we see damage to the glomerular basement membranes from diabetes, multiple myeloma, HIV, lymphoma, connective tissue disease such as lupus. All these damage the glomerular and cause protein to get filtered, wasted through those podocyte foot processes because they're not actively filtering the protein normally, and that causes proteinuria. That's the big type of proteinuria that we see. I mean, you can have tubular interstitial. Sometimes NSAIDs and nephrotoxins can cause that type of proteinuria. Secretory or overflow proteinuria, which we see in myeloma. That's another type of proteinuria. But here's my question to you. How much proteinuria is too much? What's your threshold to decide when to pull the trigger on proteinuria? Normal amounts of proteinuria is less than 150 milligrams a day. Nephritic is 150 to 3,000. Nephrotic is more than 3,500 milligrams in a day, or more than 350 milligrams per millimole per day. That's nephrotic. Most cases of nephrotic proteinuria, we always do a kidney biopsy because that's a significant amount of proteinuria. And if we did nothing, that patient probably will end up on dialysis. And whatever the underlying process is actively destroying their kidneys. So that's why we make a big deal about proteinuria. Because whatever's causing the proteinuria is damaging their glomerular basement membrane, their nephrons, and over time that damage is permanent. It's irreversible. So albuminuria, less than 30 milligrams is normal in the urine. Microalbuminuria 30 to 300. Macroalbuminuria is more than 300. So that's how we kind of quantitate and look at the amounts of protein in the urine. So how do we treat it? The main treatment for proteinuria is you treat the underlying cause. If it's diabetic proteinuria, you treat the diabetes. If it's hypertensive proteinuria, you treat the hypertension. If it's myeloma, treat the myeloma. Now, our main goal is to decrease the proteinuria to half, or at least a 50% reduction in the proteinuria or the albuminuria. And one of our mainstay drugs outside of just treating the underlying condition is to treat them with ACE inhibitors or angiotensin receptor blockers. These drugs act on the renin angiotensin-aldosterone system, and they help to lower proteinuria. So this is our mainstay drug. Matter of fact, this is the #1 prescribed drug by nephrologists, those ACE inhibitors and ARBs. So we usually give it to patients who have proteinuria more than 300 milligrams a day. So you can feel free that if a patient comes in your clinic and they have proteinuria more than 300 milligrams a day, by any cause, you can give them these drugs. Now, the urine protein to creatinine ratio, that's how we quantitate it. We take a spot urine sample, take the urine protein divided by the urine creatinine. That gives us the amount of proteinuria in grams per day. So that's a really easy, quick way you can tell what your patients are spilling, how much protein they're spilling in the urine. So, like I said, you want to reduce proteinuria by 50% in the first 6 months to a year if possible. Sometimes these patients have a lot of swelling, a lot of edema, because they lost a lot of albumin, which is the main oncotic agent in the blood, and so they lose a lot of fluid in the interstitial spaces. So we give them diuretics to help with just getting some of the fluid out. The diuretics, they don't really help with proteinuria per se, but they do help with the fluid issues. Now the calcium channel blockers, the non-dihydropyridine calcium channel blockers, such as diltiazem, verapamil, that class has a tendency to decrease proteinuria more so than the dihydropyridine calcium channel blockers. So you got a patient in clinic that maxed out on ACE inhibitors and ARBs, and you want to know what to do, what medicine to add. Their blood pressure is still elevated, or they still have proteinuria and their blood pressure is not bottoming out or anything. You can add a verapamil, you can add a diltiazem, or you can add amlodipine or nifedipine. Now, all these agents lower proteinuria somewhat in addition to what the ACEs and ARBs are doing. So feel free to add that to your regimen. Proteinuria is one of the things that we make a big deal about in our clinic because we know that is a sign of glomerular injury, glomerular damage, and is the first sign of kidney disease. And it has prognostic value also. So I want to encourage you as a primary provider, check these urine protein to creatinine ratios, check these urinalysis, get a handle on how much protein your patient have in the urine, and you can follow it over time to see if you're actually reversing that process. That's what we normally do. We'll try to follow that proteinuria over time. Like when we first see a patient that had 2.5 grams of protein in the urine, we put them on an H&R, we max it out. Over the next 6 months, it comes down to 500 milligrams. Well, we've significantly helped that patient lower the amount of protein in the urine. And that's usually what we try to do. We try to hit it really, really hard and get that proteinuria level down to normal so that the patient we can take pressure off those kidneys. So that's our goal with proteinuria. I hope this is helpful. Talk to if you're a primary provider, if you're a nurse practitioner, PA, or a doctor, talk to your patients about proteinuria. Explain to them why you're checking it and the value of knowing how much protein in the urine. And if it's really excessive, try to get them to nephrology. Thank you for tuning in. Check out our next video, and we have a webinar that you can check out. It's free. Check it out, and we will see you in the next one. Thank you. Bye-bye.